In this narrated lecture, you'll be learning about the field of epidemiology as it relates to community health nursing. You're going to learn how to calculate rates and engage in prevention practices to improve the health of population groups in the community. The definition of epidemiology is essentially the study of the distribution of determinants of health like disease and chronic conditions related to the events in a specified population and the application of this study to the control of health problems. Epidemiologists search for causes and other factors that influence health-related events. They provide the how and why of events by comparing groups with differing rates of disease occurrences, differences in demographic characteristics, genetic or immunologic makeup, behaviors, environmental exposures, and other risk factors. So let's explore a real-life case of how epidemiologists found a new disease condition. This first case happened back in the 1979-80 time frame, and there was a physician in New York that reported to the Centers for Disease Control and Prevention that he was seeing an increased incidence of Kaposi sarcoma in his patient population. In addition, the presentation of the disease appeared to be different than that was normally seen. There was also a physician in San Francisco at about the same time that reported to the CDC that he was also seeing an increased incidence of Kaposi sarcoma and pneumocystis carinii. So an investigation was begun. Here is a table that explores the cases of Kaposi sarcoma before the 1979 to 1981 distribution of cases. They're doing a comparison between 1961 to 1979 and then 1979 to 1981, where you can see the number of cases clearly jumps and is excessive in comparison to what it had been. And then an investigation of the average age affected. It's a very much younger group of patients. And then their mean survival time is much shorter. It's only 2 years instead of 8 to 13 years. And all of the cases were homosexual, whereas none had been before that. And the average number of sexual partners was 85 compared to just one sexual partner in the years preceding that. This table explores how many of the cases were men. So in the first year that it was examined, in 1979, all 10 of the cases were male. In 1980, all of them were male. There were 26 cases and 26 were male. The next year, 71 out of the 72 cases were male. And so this was suggesting that there was a male-to-male transfer of the condition. So they had to sit back and think, okay, what do we know to start out with? We know that 80% of the cases were happening in California and 20% of the cases were in New York. The cases were dramatically increasing. Almost all of them were male. Almost all of them were homosexual. They also determined that the age at onset of Kaposi sarcoma was much younger than usual, and that the mean age of survival after their diagnosis of Kaposi sarcoma was much shorter than usual. At this point, they made a new diagnosis for an unknown viral disease, and they called it the gay-related immunodeficiency, or GRID, which we now know today as HIV and AIDS. In 1982, they renamed it HIV because they found that the disease was not specific to just gay men, and so they changed the name of it. But that's how they started the investigation into what we know as today's HIV and AIDS epidemic. This is another case that happened here in Indiana a few years ago in Johnson County, when a patient that was 2 weeks old presented with diarrhea, a mild fever, vomiting, and dehydration. The doctor started fluids and antibiotics on this baby, but the patient developed cardiac irregularities, went into a coma, and died. Blood studies showed an infection with salmonella. The cultures were sent on to the Indiana State Department of Health, and they identified the serotype as being Salmonella puna. That didn't really have any significance at that point. But they had to stop and think, okay, what do we know about this case? Well, they knew that it was an extremely young infant, and that infant had been doing well up until the development of symptoms 3 days prior. And that the S. puna subtype is only seen in reptiles. 3 weeks later, another single case of salmonella in a young infant was reported from a Johnson County hospital. 2 days later, another physician reported a salmonella case in another young infant, and that infant was hospitalized. That same day, another infant from a different hospital in Johnson County was diagnosed with salmonella. The cultures were sent on to the Indiana State Department of Health lab. The lab reports confirmed that it was salmonella, and that the subtypes were Salmonella puna and Salmonella marina, both of which are only seen in reptiles. So this was significant. An investigation was performed. When they went to the homes and did home visits, they found that the homes of the patients were relatively affluent, and they also found that the mothers had washed the baby bottles and or their babies in the kitchen sink. And then upon further investigation, they found that the Johnson County Fair had been held previously, and that chameleons were given to children as prizes, and that those cages that the chameleons lived in had been washed out in the kitchen sinks prior to a baby or a bottle being washed there. So the mode of transmission was from the kitchen sink to the baby. So outbreak investigations start with confirming that there's an epidemic. An epidemic is when there's our case numbers clearly are above their normal rate. Then signs and symptoms are confirmed, and cases are described by person, place, and time. And then a hypothesis is built and tested. And then interventions are developed and tested. In epidemiology, we use rates to express the extent of disease in population groups. So rates are a measure of the frequency of a health event in a defined population during a specified time period. So for an example, it would be the number of cases of influenza at Anderson University in February. They're calculated as the number of cases occurring in a period of time divided by the number of people at risk during the same period of time. And then you multiply that times any base multiple of 10 that results in a rate above the value of 1. So why are rates used? Well, here's an example. This year, if we had 100 cases of syphilis in our county with a population of 750 people at risk, this would indicate a serious problem. Compare that to 100 cases of syphilis in a major city with a population of 750,000. This would be a very low rate. So rates take the size of the population into account. A note about the denominator. Remember that the denominator is the number of people at risk. In this instance, it was the entire population of Anderson University because anyone can get the influenza. But if you're looking at ovarian cancer, you just have the total number of women in an area listed. Here's an example of how we calculate rates. We have Brown County for a 1-year period that has an AIDS rate of 17 cases in 114,000 population. We multiply that times 100,000 and we get an AIDS rate of 14.9 cases per 100,000 people. Compare that to Orange County for the same 1-year period. Their AIDS rate is 156 cases divided by 1.2 million people. And we multiply that times 100,000 and come up with an AIDS rate of 12.3 cases per 100,000 people. So, as you can see, Brown County actually had the higher rate of AIDS at 14.9 cases per 100,000 people than Orange County, which had 12.3 cases per 100,000 people, even though Brown County had fewer cases than Orange County. Incidence rates measure the pace at which a new illness occurs in a previously disease-free group of people. So an incidence rate is calculated as the number of new conditions occurring in a period of time divided by the population at risk during the same period of time, multiplied by a base multiple of 10. So this is a measure of the probability that people without a certain condition will develop that condition over a period of time. Prevalence rates, on the other hand, are used to measure the total burden of a condition or illness that exists in a community. It's calculated using the number of existing conditions or events occurring in a period of time, divided by the population at risk during the same time period, and multiplied by a base multiple of 10. So both incidence rates and prevalence rates are measures of morbidity or illness. With knowledge of the prevalence of morbidity within a population, nurses and other healthcare professionals can plan for services to meet the needs of the community. They help us to determine the necessity for facilities or programs and staff to address the problem and develop targeted interventions. For instance, if prevalence rates of STDs tell us that middle schoolers aren't typically sexually active yet, we can target this age group with education and prevention efforts and save screening and intervention efforts for high schoolers or college-age kids. Here's a practice problem. In Pretend City, between January 1st and December 31st, there are 35 new cases of AIDS that were diagnosed. There were a total of 300 cases on the list of active cases on December 31st. The population of Pretend City is 400,000. So calculate the incidence rate and the prevalence rate per 100,000 during that year. Now, note that when you write the answer, you have to be sure to write the number and then add per 100,000. Otherwise, the rate means nothing to the reader. So they might be asking, is it 75 cases per 100 population or 75 per 100,000? Also, you should know that the new cases are already included into your number of existing or active cases. Go ahead and calculate those rates. This is the epidemiological triangle that we use to try and prevent the spread of a disease. We work to kill the agent or protect the host from contamination or alter the environment so that the two never meet. And we do this through post-exposure prophylaxis or treatment of patients. We do it by recalling or destroying contaminated food. We give educational information so that a person stays away from contamination or illnesses. We close eating establishments if they are proven to be unsafe. We exclude people from work or school or daycare if they are ill. And we also do it by making public announcements. So let's look at a historical perspective of how we fought disease in the United States over time. Starting back with industrialization in the late 1800s, there was a shift of people from the country to the city, and we also had a lot of immigration at that time. So those things led to overcrowding and inadequate public water supplies for the number of people who lived there, and also inadequate or non-existent waste disposal systems. So in 1900, the three leading causes of death were pneumonia, tuberculosis, and diarrhea. All of those are communicable diseases. And then during the early 1900s, 40 of the 45 states established health departments that began working on public health by improving sanitation and hygiene, by preventing infection through the provision of clean drinking water. In 1918, one of the most devastating epidemics in history occurred. It was the 1918 influenza pandemic that resulted in 20 million deaths, including 500,000 people in the United States alone in less than a year. Animal and pest control contributed to disease reduction. For instance, malaria used to be endemic throughout the southeastern United States, but regional mosquito control programs reduced this to a minimal level. In the 1930s through the 50s, we saw substantial improvements in disease prevention activities, including sewage disposal, water treatment through chlorination, food safety, solid waste disposal, and public education about hygiene, like food handling and hand washing. In the 1940s, penicillin was developed for medical use for the United States military to treat their soldiers. In 1955, the Salk poliovirus vaccine led to federal funding of state and local childhood vaccination programs. In 1962, the Vaccination Assistance Act was passed, which has been renewed continuously ever since. Because of this, there's been a virtual elimination of diseases that were very common in the United States at that time, including diphtheria, tetanus, polio, smallpox, measles, mumps, and rubella. However, it has to be noted that we may see a reversal of some of this progress because of people refusing to vaccinate their children. So fast forward to the year 2000, in which the three leading causes of death were heart disease, cancer, strokes. All of those three things accounted for 67% of all deaths in the United States. So over time, our emphasis has had to shift from the investigation of communicable diseases to determining the role of behavioral risk factors, environmental risk factors, and also preventing disease, disability, and death from chronic illnesses. In Indiana, we have higher rates of death from most chronic diseases compared to the United States. Our top three leading causes of death are heart disease, stroke, and cancer. And we have some major risk factors. We're the fourth highest obesity rate, and we have the sixth highest smoking rate. And we know all of this because we track health and conditions using a wide variety of data sources. For instance, our vital statistics, which contain our birth and death records, hospital discharge data for those people who are in the hospital for 24 hours or more. We have a national notifiable disease network where we have notifiable diseases that vary from state to state. We have 55 in Indiana, but there are over 100 in California that are notifiable diseases. And then the census, we use that data because it gives us the denominator for our rates that we calculate. We track morbidity and mortality reports, and the CDC publishes a weekly report called the MMWR, the Morbidity and Mortality Weekly Report. And you can see the other ways that we get our data listed on the screen there. So how does epidemiology fit with traditional medical care? Well, epidemiology focuses on population groups, whereas clinical medicine really focuses on individuals. Epidemiology also focuses on prevention, where clinical medicine focuses on treatment. So both are focused on improving health, but they view the patient very differently. And so when we work in prevention, we work in three different levels, the first of which is primary prevention. And the focus here is not allowing the disease to occur in the first place. We do this by risk reduction and focusing on behavioral change and through education and immunization. Secondary prevention focuses on not allowing the disease to continue or progress. And so our focus is on finding an illness early so that it can be treated early. So we do screenings and we treat diseases so that they don't progress. Tertiary prevention restores a patient to their optimal level of health, and so we do this through rehabilitation and support groups. These three levels of prevention fit in with the goals of Healthy People 2020, which has a goal of preventing disease and disability and death from infectious diseases, including vaccine preventable diseases. And you can see some of their efforts listed there. So people working in community health definitely have their work cut out for them. But epidemiology gives them the means to identify where to put their scarce public health dollars.